The patient was a 62-year-old female with squamous cell cancer of the right retromolar trigone with mandibular involvement. The patient was a candidate for a virtual surgical planning, jaw-in-a-day approach for mandibular resection and reconstruction, using a fibula osteocutaneous free flap and dental rehabilitation. A neck dissection will be performed, removing lymph nodes from levels 1A, 1B, 2, and 3. The facial artery and vein will be divided. A 1 cm margin will be planned around the edge of the tumor. The right first premolar tooth will be removed, and the right mental nerve ligated and divided. Prefabricated patient-specific cutting guides will be secured to the exposed mandible with screws. With the cutting guides in place, ensuring precise measurements, pilot holes will be drilled for the mandibular plate. A mandibulectomy will be performed with a bone saw, dividing the mandible body interiorly first. The posterior cutting guide is used to start the posterior osteotomy through the ramus towards the sigmoid notch. This will be completed without the aid of the cutting guide. The pathological mandible specimen will then be removed. An ipsilateral fibula osteocutaneous flap harvest will be performed. Skin paddle position is based off perforator location, measured from preoperative CT angiogram. After identification of the perforator takeoff from the pedicle, the precise location of the skin flap island and fibula cutting guide placement can be determined. The fibula cutting guide accounts for the precise length of the fibula bone graft, as well as the angles of the bone cuts, and provides pilot holes for the mandibular plate screws and guide holes for the dental implant sites. There are 2 ways to guide dental implant placement. In most cases, pilot holes for dental implants will be drilled with the fibula cutting guide in place, while the bone is still perfused in the leg. Alternatively, using a prefabricated occlusion guide, pilot holes can be drilled with the fibula graft in the mouth. After the bone is reperfused, the fibula flap will be brought up to the patient's jaw and the cutting guide removed. The anterior surface of the fibula graft will be oriented superiorly, as appreciated in the axial profile. The bone graft will be aligned with the osteotomy sites in the patient's oral cavity, and using the same pilot holes from the fibula cutting guide, the titanium alloy mandibular plate will be secured to the mandible. A microvascular anastomosis of the artery and vein will be performed. Use of the patient's ipsilateral fibula will ensure an optimal surface for dental implants. Following assessment for canting and axial loading, implant guide pins will be removed and replaced with implants, multi-unit abutments, and temporary cylinders. The dental prosthesis will then be tested to assess occlusion. The skin flap will be rotated into position, forming a trough or sulcus, and sutured in place to cover the defect in the oral cavity. The implants are brought out between the interface of the fibula skin with the native floor mouth mucosa. The neck exposure will then be closed, concluding the procedure.